Good afternoon, everyone. I'm Yong from Samsung Medical Center, Seoul, Korea. These are my disclosures. MSA, minimum stent area, is the most important prognostic factor after PCI, rather than relative stent expansion in the current DS era. In calcified lesions, calcium angle, thickness, and length are major determinant for stent expansion. In the study using OCT, calcified lesions greater than 180 angle, thicker than 0.5 millimeter, and longer than 5.0 millimeter were significantly associated suboptimal stent expansion. Therefore, in dealing with calcified lesions, lesion preparation is the most important procedural step for plaque modification and lumen expansion. Optimal lesion preparation facilitates device delivery, minimizes severe dissection, and obtains larger MLA. There are several devices for plaque for lesion preparation in calcified lesions, including balloon-based devices for a simple strategy and atherectomy devices or lithotripsy for complex strategy. A recent paper nicely summarizes an algorithm for approaching calcified lesions. Balloon crossability is a starting point. If balloon cannot be crossed, consider rotational or orbital atherectomy. If microcatheter cannot be crossed and wire exchange cannot be done, consider direct wiring using Ruta wire or Viper wire. If direct wiring is not successful, consider laser treatment. After atherectomy is done, but optimal balloon expansion is not achieved, consider lithotripsy. In cases balloon crossability, but predilation is inadequate, intravascular imaging can be considered. If calcified lesions are severe and the calcium is located superficially, consider rotational or orbital atherectomy. If calcification is deeply located, consider lithotripsy. If calcification is not severe, consider non-compliant balloon or cutting scoring balloon. If optimal balloon expansion is not achieved after this balloon technique, consider lithotripsy. Unfortunately, I don't have any experience in orbital atherectomy or lithotripsy because these devices are unavailable in Korea. Therefore, I would like to focus on rotablation. When do you have to consider rotablation? Angiographic heavy calcification, balloon uncrossable lesions, superficial calcium, and the minimal lumen diameter smaller than rotablation burst size are a good candidate for rotablation, especially before severe dissection occurs. When difficulty in device delivery and lesion preparation concerns, elective rotablation would be better than bailout rotablation. Relative contraindication included severe angulation, extremely eccentric lesion, vessel sizes too small, pre-existing severe dissection or vasospasm, or high risk of no reflow. Let me share several cases. A 77 female patient presented with unstable angina. PCI was failed in another hospital due to incrossability of a stent. You can see severe calcification in proximal and medial RCA. I performed rotablation with her 1.5 millimeter. Because lesion was long, I sequentially performed rotabulation at proximal RCA and mid RCA. I do not routinely implant a temporary pacemaker, but in this patient, heart rate decreased during rotabulation, so I had to implant a temporary pacemaker. After rotabulation, I had still some difficulty for balloon crossing. With Budweiser technique, the balloon was crossed and successfully dilated. After that, to ensure adequate expansion, I performed non-compliant ballooning. After that, 2 drug-eluting stents was successfully implanted. This was a final IVUS images. Stent expansion was acceptable without severe complication. The second case was an inadequate balloon dilation. A 80-year-old female patient presented with non-STEMI. The patient refused to undergo CABG and was referred to our center. There was a severe calcification with a very tight stenosis and in left circumflex ostium, and there was another CTO lesions in the proximal LAD. I performed pre-dilation at the circumflex lesion, but the expansion was inadequate and the residual stenosis was substantial. I had to perform rotabulation. After rotabulation, huge dissection occurred. So I had to implant drug-eluting stent from the left main to the proximal left circumflex. After stenting, the circumflex looks okay. The wiring was not so difficult for LAD lesions, and the balloon was crossed and expanded. And after that, another DS was implanted at the proximal LAD using TAP technique, and the final kissing balloon was performed. Final angiographic images looks satisfactory. Sometimes for calcified lesions, elective lesion preparation are needed. A recent study reported the comparison between rotabulator modified balloon, such as scoring cutting or super high pressure balloon, so-called OPN balloon. In this study, there is no significance in stent expansion between the 3 devices. With regard to stent eccentricity, the super high pressure balloon was better than the other 2 devices. However, most importantly, for strategy success, rotational atherectomy is best among the 3 devices. Therefore, when you consider elective preparation, rotabulation would be the first choice. Case 3 is for elective rotabulation. 79 female patient presented with unstable angina. There is a severe tight stenosis with calcification at the proximal LAD. I performed elective rotabulation using 1.5 milliliter borehole. After rotabulation, I performed IVUS. You can see the reverberation suggesting successful ablation. Calcium was cracked, but the expansion was not adequate. Therefore, I performed non-compliant ballooning, and after that, I performed the IVUS again. Expansion was improved, and calcium was cracked more. After that, I implanted 2 drug-eluting stents, and I performed post-dilation. Final angiography looks satisfactory. And this is final IVUS images. Stent expansion opposition looks acceptable without important complications. Case 4 is a bailout rotabulation. 63 male patient presented with unstable angina. Coronary angiography revealed very tight stenosis with the LAD with the calcification. I first performed pre-dilation After that, substantial dissection occurred. Stent was not passed, even if body wire technique and another ansibolony. Therefore, I had to perform rotablation despite huge dissection. Fortunately, rotablation was done without complication and drug-eluting stent easily passed. This is the final angiography that looks acceptable. And final iris images showed acceptable expansion without any complications. In meta-analysis of 5 retrospective studies, there is no difference between elective versus bailout rotational atherectomy with regard to angiographic success in hospital MI, death, future MI, TVL, stent thrombosis, or MACE. However, elective rotabulation significantly reduced procedural time, contrast to use, and the total number of stents with less dissection. For successful rotabulation, we should be familiar with the proper technique. Birth to artery ratio is recommended as 0.5 for most bore. 180K RPM is recommended. For larger borehole, 150K RPM is recommended. To and fro packing motion is essential for prevention of borehole entrapment. Always keep the burr advancing or retracting while it is rotating. Never stop, run in the target lesion, and do final polish run. In summary, calcified lesions are challenging for optimal stent expansion. Sufficient lesion preparation with imaging guidance are the key to procedural success and the patient's prognosis. Rotabulation is a useful tool, especially for superficial calcium, narrow lumen, and device passive failure. Elective rotabulation is better than bailout rotabulation for shorter procedure time, less contrast agent amount, and a low number of stents used. When you are facing severe calcification, expecting difficulty in procedure, and thinking to or not to do rotabulation, the correct answer is just do it safely. Thank you for your attention.